Well, welcome everybody. It's an exciting topic, and I'm really pleased to present my personal opinion and view about post-ectomy, how we can address it with the hub and spoke. You will see I'm going to present the British experience and the British perspective. This might be different to the next presenter who is giving you an overview about the German experience, but I'm quite excited to share my understanding of post-cardiotomy cardiogenic shock. Let me start with a nice paper, a really nice paper of my colleague, transplant director at the Willinshaw Hospital in Manchester, Venkat, who was focused and published this nice paper in 2019. And he was very meticulous in addressing the point of venous arterial Ecmo for post-cardiotomy cardiogenic shock with a 6-year service evaluation of the Manchester experience. What is important, where I would like to highlight, is that you need to understand, all of you, that only a small number of English hospitals provides a post-cardiotomy, a Ecmo service, and there are doubts about its efficacy and safety. And I hope that in the next 10-15 minutes, I can convince you that there are no doubts about the efficacy and the safety. What is important for you to know that post-cardiotomy cardiogenic shock is really something that no cardiac surgeon wants to see and wants to experience. But unfortunately, once in a while, we are basically confronted with this, some kind of catastrophic situation that you do your very best, and at the end of the surgical procedure, you end up in a real situation. And you're not alone. And if you look at the PubMed results, and if you type in post-cardiotomy cardiogenic shock, it's interesting, and we can highlight it a little bit. In 2020, there were 50 publications. So there's an increasing interest, an increasing need to address the post-cardiotomy cardiogenic shock treatment of our patients. And if we go a little bit back, and I brought you one paper addressing the extracorporeal membrane oxygenation in general for the post-cardiotomy cardiogenic shock by Delos Cosgrove in Cleveland. And they observed over 22 months, 23 patients, placed them on VA Ecmo. They had an overall survival of 30.4%, which were successfully discharged home. So 1/3 of the patients are successfully weaned off the Ecmo and can go home. However, if you look at the blood product in these publications, you're quite surprised and you're a little bit confused. What does it mean, 43? Well, these were 43 packed red blood cell units, 10 units of frozen plasma, 58 units of platelets, and 51 cryoprecipitate. And now you think, well, what is he talking about? Well, this is a publication which has been published in 1996. And the patients were cohorted, it was a cohort starting from 1992 to 1996. So these are historical data. And this historical data revealed some kind of a problem of the early use of ECMO on our ITUs. And we all know this one, if you're a little bit older, we all know this leaking of the oxygenator, the plasma leaking, and understanding that we need some kind of this plasma and cryoparticipate because bleeding at that time was just catastrophic. The oxygenator moved forward, and we're in a little bit better situation if it comes to the equipment. However, we continue to have some kind of limitations. And I'm very pleased about Vipin, who is now working in Manchester as well, together with Navar in Glasgow, doing this fantastic work, extracorporeal membrane oxygenation for the cardiogenic shock, and they did a meta-analysis. And this meta-analysis compromised a little bit more than the 22 patients we have seen beforehand. It's now 1,926 patients, and it compromised the time between 1992 and 2016. And what is some kind of sad, that the overall discharge home rate is 30.9%. And if you think about in 1996, the discharge home rate was 30.4. So it is not really increased over the last 20, 30 years, actually, of cardiac surgery. So we continue to have some kind of severe challenges, and the challenges need to be addressed. And I'd like to address it in the following, that we can think about how can we improve? How can we improve the post-cardiotomy outcome? And of course, my presentation is going to be strictly on the perioperative management, and it will be focused on ECMO. But there are 3 important issues. It's from the patient selection, it's the timing of the intervention, and it's the post-management of the ECMO afterwards. So allow me to start with the case presentation. So we have a 57-year-old male patient who was admitted with an acute endocarditis, large vegetations on the non-coronary cusp of the aortic valve with a free aortic regurg. He was in cardiogenic shock, and it was a colleague who was asked for emergency procedure, and he asked me for backup in case that he is going to run in trouble. And then whenever you consider, maybe I run in trouble, Murphy's Law is going to catch you. And indeed, he ran in trouble. It was an emergency AVR with patch repair of the aortic root, very complex. And my colleague is a really good surgeon. Nevertheless, it was challenging. And unfortunately, during the reperfusion, there was a paravalvular leak requiring a second cross clamp. So at the end of the repair, and it was a good repair, there was no regurg existing afterwards. Unfortunately, he failed with an attempt to wean off cardiopulmonary bypass due to right heart failure. So the question, of course, arises what to do. And of course, in general, this is the Harefield understanding. Is the Ecmo selection criteria is we need patients with a realistic chance to wean off Ecmo, or a candidacy to durable mechanical assist means with LVAD, or then in the later step to transplantation. We understand that the criteria should be age less than 70 years if you attempt for wean. And if you want to go down the route for the transplant pathway, you need to be less than 60 years. Even so, this is not concrete, but it's just some kind of, it's going to be some kind of a general understanding. The chance of recovery needs to be clear. It makes no sense if you haven't solved the problem. So you need to solve the problem. So if you come off bypass with an ongoing large paravalvular leak, that's not going to work. And it makes no sense to say, well, let's come and hope for a miracle. We all know miracles won't occur in these kind of settings. And of course, for the UK, you need to have no exclusion criteria for transplant allowing dual mechanical assist. In the UK, dual mechanical assist are only commissioned for patients who theoretically undergo transplantation. So if you have recent cancer, or if you have strict contraindication for a transplant, unfortunately, these patients don't qualify for potential ECMO wean and then later on. It needs to be less than 6 hours in cardiopulmonary bypass. I believe this is quite important, in particular if you have centers, and I'll come later. We have centers in the UK, about 50% who have no ECMO access. So if you ask us to help you, we are happy to do so. However, we have the time limit, which needs to be less than 6 hours, because the outcome after 6 hours on cardiopulmonary bypass to switch on ECMO is not really good. So we did an MDT discussion, very quick, surgeon, anesthetist, critical care. And we decided it's a 57-year-old patient with no past medical history. He had bad luck getting this endocarditis. He was on no medications. He had a fixed root problem, and he had a single organ failure. And then in the end, we decided to convert cardiopulmonary bypass to central ECMO with stented chest. So this central ECMO is going to be the point I will come to in a moment. But we believe that in this particular situation, if you have some kind of no sternal bleeding and you have some kind of good control of the bleeding, it's an appropriate way to move forward. When to implant these ECMO, it's always a question. Should we do it when you're in theater, when you're on bypass, struggling come off bypass? Should we do it in theater after coming off bypass, once you close the chest and it's going to be a little bit wobbly, and you say, well, that's not really good, let's go on ECMO afterwards, or do you do it on ITU? There's some kind of little bit this, if you ask 3 surgeons, they might have 3 different opinions. My personal opinion follows the group from the Fuwai Hospital in Beijing with Shengshu Hu, where they looked for the combination of the balloon pump plus extracorporeal membrane oxygenation. And what they see, and you can see it beautiful down here, if you do the bedside implantation, you have a survival of 12, and if you do it concurrently with the balloon pump in theater, and their concept is first they implant the balloon pump to try to come off bypass, and if this fails, then they go on ECMO. So they recommend, and I personally recommend as well, don't do it afterwards. If you struggle, don't be a hero. Go straight on the ECMO, convert from the cardiopulmonary bypass to ECMO, and then you can decide whether you leave the chest open or close the chest. The management, now the question, is it central or should we go for peripheral? There is a new publication published in 2020, which is an interesting paper, and they looked for the outcome, and they looked for 3 different points. It's some kind of the bleeding, the mortality, the bleeding, and the blood transfusion rate. And in all 3 groups, the peripheral cannulation was superior to the central cannulation. So you might say, well, haven't you read the paper from 2020? No, I read the paper from 2020. However, the right heart was quite struggling, and the idea was behind to leave the chest open. And if you leave the chest open, I personally believe if you have no bleeding and the bleeding is under control, and you have a little special retractor to keep the sternum apart, to give the heart a little bit more space, I personally believe you need to decide on an individual basis whether you close the chest or leave the chest open. And once the chest is open, I personally believe you can leave the cannulas in and you don't need to go for peripheral cannulation. The post-operative management is quite important. And what we did and what we try to aim, we forget about trying to wean off the Ecmo after establishing in the first day, because normally the first day after cardiopulmonary bypass, patients are vasoplegic, they need vasopressors. They're normally positive fluid balance. In this particular case, the patient was 2 liter positive fluid balance on a 4.5 liter Ecmo flow. However, the next day, the vasoplegia was better. We managed almost an even balance. We continued to leave the full Ecmo flow. And then the day 3, when they basically had just a pinch of noradrenaline, and we could start the patient with a negative fluid balance, we reduced 1 liter and reduced the flow every 12 hours by half a liter. And we continued in the day 5. We were able, with 2 liters of flow, to explant successfully the Ecmo in this gentleman. We aim for weaning of the Ecmo in the first 7 days. We can do it a little bit longer, but we all know after 7 to 10 days, you normally start with bleeding and complications. And once you fail to wean a patient post-cardiotomy of the Ecmo in the first 7 days, you will never have a chance to wean afterwards. Now, the next question is going to be some kind of, and I come back to Venkat's paper, because Venkat made it very clear. We suggest that post-operative Ecmo should be available to all patients undergoing cardiac surgery, be it in their own center or through an established pathway to a specialist center. And I'm quite pleased that I was involved with our cardiologist, Miles Darby, and the Society for Cardiology and Critical Care, together with the Society of Cardiothoracic Surgery. We looked for a UK position statement for cardiogenic shock centers in general. It's not only for post-cardiotomy, but in general. And if you look at some kind of, we have 3 different levels. It involves the interventional cardiology. But what is important down here, that you need to have a look that only 16 centers in the UK have short-term MCS ECMO access out of the 31 cardiac surgical departments. And of course, we only have 6 centers who do durable mechanical assist device and transplantations in the UK. So if you know that 16 have the access and the luxury kind of to have an ECMO in order to support the patients, we know that 15 don't have the access. So we need to work in the UK that we have some kind of a unique access, either that you have ECMO in your own department or access with another ECMO retrieval center. And we're very proud with our ECMO retrieval center at the Brompton with Richard Trimblett and Susanna Price, who are very some kind of motivated to reach out to supply a service. However, unfortunately, in the National Health Service, we are not commissioned for VA ECMO. We are fighting for commissioning in order to provide the service on site. That's a luxury of having the opportunity to wean off patients with struggling hearts after cardiac surgery, have some kind of a broader access. And I'll come back to my first slide with Venkat. I need to make it very clear that there are no doubts about its efficacy and safety. We need to work together with the society in order to have some kind of a unique access in the United Kingdom, to have access to VA ECMO for every cardiac surgeon who's struggling at the end of surgical procedure. I'd like to thank you so much and look forward for your questions.
Dear Chairman, dear colleagues, it's a pleasure for me to speak in front of this auditorium on bridge strategies with percutaneous mechanical circulatory support. These are my disclosures. I would like to start with the principle of bridging patients with hemodynamic instability. To build up a therapeutic strategy, it is important to know where the patient comes from, what is his initial state, what is the gap that has to be bridged with the mechanical circulatory support modality, and what is actually the available destination for this patient. When we look into the guidelines, And this is one of the current statements issued by the American Heart Association. We see that patients with cardiogenic shock and hemodynamic instability should follow a certain therapeutic path where certain therapeutic steps like intervention, be it interventional or surgical, and also pharmacological steps should be taken in order to stabilize the patient, to bring him to recovery. Or if a recovery is not in sight and also more durable bridges are not possible, palliation can be initiated. Today, we would like to speak about temporary mechanical circulatory support systems. And as you all know, a number of different systems are available to bring the patient to durable VADs or to transplantation in case of cardiac failure. So the question is, what is the right bridge over a given gap? And in order to address this question, it is important to have the variety of different presentations of cardiac failure in front of us. And as you can see, there are all kind of different pathologies that lead to cardiogenic shock in our patients. These are just a number of presentations. As you can see, it's a rather left ventricular failure. Here's an acute cardiac infarction with a massive VSD, but also right ventricular failure or a dilatative cardiomyopathy can lead to cardiac shock in our patients. And again, according to the guidelines here, the European guidelines, a number of different therapeutic frames and goals become available in these patients. So we have sometimes patients with a clear therapeutic path with open roads to transplantation. And sometimes the patients are not so clear in their overall health status. And some of these patients to bridge, and also patients with a good chance of recovery may from now and then become a candidate for percutaneous mechanical circulatory supports. These are typically patients with a myocarditis, for instance, and also some patients with destination therapy with no obvious option for transplantation. So all of these patients are candidates for some kind of mechanical circulatory support. And as we all know, VA Ecmo has been out there for a number of years. It's probably the most widely used option. There are a number of good reasons to use this system. It's fast, it's robust. However, we know that patients on VA Ecmo are at considerable risk for a number of different complications, such as vascular injury, increased myocardial wall stress, and congestion is actually a very strong argument against the sole use of VA Ecmo, and also decrease of coronary blood flow and myocardial oxygen demand. So we actually analyzed our patient cohort that has been treated in our center. We have a quite active out-of-hospital Ecmo program, and this is just one of the slides of our early publication. These were the first 115 consecutive patients with out-of-hospital, so to say, rapid response, ECPR. And you can see that actually survival up to 1 year and also beyond 1 year is quite favorable if we have a certain criteria, such as no or short CPR, or young patients, young adolescents and young adults. However, outcome is quite poor if we have advanced age in combination with prolonged CPR. And this is actually a key message every time we discuss with colleagues from other disciplines in how far we should continue these programs. We analyzed our patient cohort, and we found actually a large variety of different pathologies that have led to a cardiogenic shock in these patients. As you can see here, the biggest group were, of course, acute myocardial infarction, but also some other pathologies such as septic shock and also arrhythmias were present here. Of the 115 patients undergoing Ecmo implantations, we had, unfortunately, a mortality of almost 50%. And in this early phase, cerebral complications were the predominant cause of mortality. When we look at the survivors, we see that all kind of different interventions and also surgery has been a crucial component to bring these patients to the next step. We had 50 survivals until primary discharge, and of these, actually 39 had full cardiac recovery, or they were bridged successfully to a more durable option such as LVAD implantation or heart transplantation. We had in the, I would say, intermediate time, 11 patients dying after VA ECMO weaning, and of these, the majority was due to multi-organ failure. So we see that rather secondary organ failure is the predominant cause of mortality, and those who survive have actually the better situation regarding end organ function. So at the end, we had 37 patients with actually favorable neurological outcome and full restoration in daily activity. We went on and looked at these patients. Actually, bigger cohort. This was the second analysis we performed. We had 185 requests by then, 160 consecutive patients. And again, markers of secondary end organ failure were the significant predictors of survival and favorable outcomes. So our survivals had less NSA, less lactate, and also less liver enzymes. And this is the latest analysis, meanwhile including 438 patients. It's a single center ECMO program for cardiogenic shock. And when we look at those who survive 4 days and beyond, we see again that end organ failure is the predominant cause, and markers for end organ failure, particularly for liver failure, is the most powerful predictor of survival. So here comes the question whether a systemic injury is the predominant cause of mortality in the intermediate time window, much more than actual cardiac failure. And knowing this, the question is whether ECMO is the best percutaneous mechanical circulatory support system. We all know about Impella. Impella has been introduced to cardiovascular therapy almost 2 decades ago, and actually meanwhile quite successfully implemented at many centers. And nowadays also biventricular support has become accessible. And the major advantage of Impella is that we have true ventricular unloading, which actually leads to reduced wall stress and thereby also to reduced oxygen consumption. We can do that percutaneously and also to provide prolonged support. There are certain criteria and certain factors that may be regarded as drawbacks, such as the more enhanced implantation setting as opposed to ECMO. And also there is currently a question with regards to increased hemolysis under Impella. However, a very recent report, a multi-center report, including 686 patients with VA ECMO plus or minus Impella, has clearly shown the benefit and the power of true ventricular unloading. So this is the blue line. As you can see, patients with VA ECMO, in addition to Impella support and unloading, they have actually a significantly better outcome with regards to survival already at 30 days. And this has been also somewhat indicated by other reports, such as this one here, a meta-analysis comparing the ECMO plus Impella as opposed to IABP for ventricular unloading, and you can see that Impella is favored according to this analysis. However, there is also a drawback here. When we have 2 large systems such as VA ECMO in addition to Impella, there seems to be a higher likelihood for bleeding in these patients with Impella. So despite overall benefit regarding the hardest endpoint, survival, we may have an increased coagulopathy. So the hypothesis is whether we should have an early termination of the combined therapy, so to say, the combination of VA, ECMO, and Impella to improve further the results. And here's the hypothesis. We have a early or rapid response for resuscitation, and the VA ECMO is probably the most robust, most rapid system here, but we should have an early escalation as suggested by this large report from Hamburg. And then the question is whether we can go to early de-escalation. And here the right ventricle is actually the crucial component. When we have a good right ventricle function, VA ECMO certainly can be terminated without any other means. And if we have an impaired RV function, we need additional tools, such as these ones here. These are taken from different reports. We can have percutaneous right ventricular support, but we can also have surgical RVAD. All of these systems, unfortunately, have little evidence when we look thoroughly into the literature. However, it becomes obvious that we have now all kind of different bridges and combinations of different components to bridge the patient from cardiogenic shock to recovery or to more durable options. And this is how we would treat the patients. Currently, we have at the beginning certainly a system that is highly versatile and durable. This is the VA ECMO. At the early stage, we have a high risk of ischemic stroke or multi-organ failure, but after initial stabilization, particularly the left ventricular Impella systems are very valid options to bridge these patients, probably in combination with an RVAD support system, to bring these patients to durable LVADs. I would like to share with you some examples. This is the first case we would call the short distance winner. This is a patient who has been treated with VA ECMO and already with an Impella system for venting of the left ventricle. This was continued for 2 weeks. After 2 weeks, the left ventricle had already recovered substantially. This patient was diagnosed with myocarditis. And then as a second stage, this is not very usual, the RVAD system was then, or the ECMO system was then explanted. The patient showed complete recovery and termination of any means of mechanical circulatory support became feasible. This is a second patient, a slightly different picture, the full distance challenge, we would call that. Is a male in his 5th decade of life. He had a rapid onset of heart failure and progressive decline. Emergent VA ECMO implantation was performed on the ICU, an upgrade to the ECMella system because of sustained LV ejection. This is the picture that was present at that time. You can see even despite the Impella unloading, the left ventricle is quite hypokinetic and there is a dyskinetic septum. So after that, after further 3 weeks on this ECMella system, we decided to switch the patient to a durable LVAD with a temporary RVAD. You can see here the venous cannula of the RVAD system. And then weaning and termination of RVAD was possible after 2 weeks. And more than 1 year later, the patient was successfully transplanted and returned to daily life and occupation, actually. So actually a very successful story in this case. Another case is the vessels, peripheral. The patient already came to us with a CP, Impella CP system, underwent an emergency cabbage operation. At the end of the operation, VA ECMO was necessary to stabilize hemodynamics. After 7 days, we decided to escalate the therapy with an Impella 5.0 implantation. However, ECMO explantation was not possible due to RV failure. So we took a second attempt after another 5 days where a percutaneous RVAD implanted, and here ECMO was successfully explanted. The Impella for the left system was explanted 2 days later, and the percutaneous RVAD system finally after the 31st day after operation. And the patient was discharged home after a prolonged course, but however, she returned home, and we're quite happy that we could treat her with this different systems of percutaneous circulatory support. And this is the last case I would like to share with you. This is a gentleman who came to us again with an acute myocardial infarction. He received an impeller system first for preconditioning and, as we say, cooling down the myocardial situation. Then an off-pump myocardial revascularization was performed on impeller support, so it was without heart lung, but under protection of the impeller system. Impeller was then explanted after 4 days. The patient was discharged home. After almost or more than half a year, he underwent ICD implantation, and the LV was unfortunately perforated. He developed a tamponade, was resuscitated, and a second mechanical circulatory support system became necessary. He underwent emergency operation with LV patchplasty. He remained on impeller 5.0 for 6 days. Ecmo was explanted, and we could receive Eurotransplant high urgency status for this patient. And after 27 days, impeller was also explanted, but he was still inotropic dependent on the ICU. And when he underwent transplantation, this is the intraoperative image. As you can see, this is the patch on the left ventricular or the posterolateral wall. So this patient was fortunately transplanted on the postoperative day 75 in the second episode and successfully transferred to rehab hospital. So this is certainly a very special case that we would term the hurdle race. So these cases I would like to summarize together to highlight that innovative mechanical circulatory support tools have become available today for short and long-term temporary assist. VA ECMO may still be the first choice in some cases of severe cardiogenic shock and out-of-hospital CPR. I think this is the primary arena for this system. However, early escalation show improvement on survival. This is at least evident from the first trials. Early de-escalation may further improve results to prevent bleeding and infections and multi-organ failure. This is the hypothesis in the room that actually we are now working on together with other centers. And secondary implementation of biventricular support, ideally groin-free, is actually the key in these patients. Proof of concept is out there already. Impeller is particularly suitable in these patients. And most importantly, the large impeller systems. The ideal right ventricular support, however, yet needs to be determined. And the latest innovation, this is impeller 5.5, provides prolonged stable support and is probably the best option in these patients. With this, I would like to thank you for your attention and happy to take the questions.
Good afternoon. Thank you very much for having me here today to discuss mechanical circulatory support in post-cardiotomy shock. I'm going to start with this rather sobering slide. This is data taken from a recent meta-analysis published in 2018. And this meta-analysis has shown in-hospital mortality in the region of about 66% that has remained relatively unchanged over the last 25 years. This is data going back to 1996. And this refers to in-hospital mortality. And this is despite improving ECMO technology and increasing ECMO experience over the last 25 years. And to address these rather poor outcomes in post-cardiotomy shock, I'm going to try and discuss 7 points, in terms of approaches to MCS following cardiac surgery. And I'm going to spend a couple of minutes on each of these over the next 15 minutes or so. The first is this anticipatory approach in cardiac surgery. And the aim is to try and move MCS to a more planned or preemptive approach rather than an unplanned or a more typically reactive approach. So the panel on the left refers to a preemptive MCS strategy where there is extensive preoperative assessment in patients identified as high risk. This usually involves a multidisciplinary team, and a strategy is usually discussed, including potential candidacy for heart transplantation if recovery is not feasible. But this doesn't happen in majority of the cases. In most cases, the MCS is deployed in a reactive fashion in response to typically an intraoperative emergency. And this approach is usually driven by a surgeon. Mechanical support is usually deployed quite late. And recovery is usually the only option as patients have not been previously assessed for possibility of transplantation. And then there is a third group of patients where it is out of our hands. Patients present in a very unstable and critically ill condition. A classic example is a patient with a post-myocardial infarction septal defect, presenting with cardiogenic shock and multi-organ failure. And discussions should be around futility, perhaps consideration for non-surgical option, and perhaps also preoperative mechanical support to optimize the patient's condition prior to surgery. So these are the three approaches in MCS, in cardiac surgery, and we should be moving as much as possible to a planned or preemptive MCS strategy. The second is to stay objective and exploit the skills of a multidisciplinary team. And there are ways to try and predict outcomes on VA Ecmo following cardiac surgery. This is one of them. This is the REMEMBER score in patients with post-cardiotomy shock after coronary artery bypass grafting surgery, incorporating a number of these risk factors to calculate a score shown on your right here. And we have to stay objective because the surgeon may have done a technically very successful operation, but the patient may be very ill. And we have to be objective before deploying ECMO support, particularly in the face of futility. So if you take an example of a 70-year-old man who has undergone coronary artery bypass grafting surgery and developed cardiogenic shock, and if they have accompanying acute renal failure and low platelet count of less than 100, despite high-dose inotropes and presses, the mortality here is approaching 90% despite VA ECMO, and there should be serious discussions about futility rather than embarking on a difficult, costly, and resource-intensive VA ECMO. And an early multidisciplinary input is crucial in decision-making in these cases. The third is to have an early support strategy. And this is a typical course in a patient who fails to come off bypass because of post-cardiotomy shock. Often a patient will be placed back on bypass, perhaps regrafting of coronary arteries, and try again and fail again, going back onto bypass to rest the heart, introduce an intra-aortic balloon pump, introduce increasing amounts of inotropes and vasopressors. And even when we come off bypass successfully, patient might be facing escalating amounts of vasopressors and inotropes, leading to multi-organ failure before we consider mechanical support. Such a strategy will not work because patients has already developed a significant multi-organ failure, and the most successful VA ECMO will not be able to reverse that degree of multi-organ failure. This is an example of an unplanned reactive mechanical support. In a patient who has undergone surgery, you will appreciate the extensive lung injury with bilateral widespread infiltrate. And the patient was stable on central VA ECMO support shown on the right here, but the patient did not survive this episode. So, and again, an unplanned or reactive approach, particularly in a high-risk patient, will result in a very poor outcome. And when we talk about early support, there are some recommendations from the recent EX guidelines published about a year ago. And they have outlined two criteria for early support. The first is failure to wean from cardiopulmonary bypass. and which is obvious. The second is when you're able to wean the patient off bypass, but you're facing rising lactate. They use a threshold of 4, and what they describe as borderline hemodynamics. Now, they did not describe that or provide any guidance on how they define borderline hemodynamics. So I've taken the liberty to try and define this in a bit more detail, and I will introduce here the concept of cardiac power output, which is calculated here as the difference between the mean arterial pressure and the right atrial pressure multiplied by the cardiac output or cardiac index divided by the constant of 451. And using our experience and our data from a heart transplant population, we know that a cardiac power output index of less than 0.34, despite vasopressors and inotropes, will have a very high likelihood of requiring mechanical support. And the word of caution here, of course, is that this is a transplant population and it may not apply to the post-cardiotomy population, but nonetheless, it provides a guide as to the level of cardiac power output index that may be applicable in these patients. But the bottom line here is that mechanical support should be delivered early before patient develops multi-organ failure. The fourth point here is about the approach to the cardiac dysfunction itself. It is often not purely a systolic dysfunction problem, and it's often also not just confined to the left ventricle. Often it is also affecting the right ventricle. So this is the pressure volume loop. Shown on the left here is the right ventricle, and on the right is the left ventricle. And this is taken in patients with primary graft dysfunction after heart transplantation. So not necessarily, again, directly applicable to the other types of post-cardiotomy patients. And you will see that here that the dominant pathology here is in the right ventricle. This is using real-world patient data to simulate and generate these pressure volume loops. And the problem here is not purely a systolic dysfunction, but a stiffening of the right ventricle, shown here as a leftward and upward shift in the end diastolic pressure volume relationship, indicated by the thick arrow on the left panel. And you will see that the width of the loop has decreased as a result, indicating a reduction in the stroke volume. The stiffening of the right ventricle has two effects. The first is that it limits how much the heart can fill, so the stroke volume becomes relatively constant. And the second important point here is that because of the stiffening, because it's unable to increase the end diastolic volume, it is not able to exploit the Frank-Starling or the length tension relationship to generate increase in stroke volume. So the dominant pathology here is the right ventricle. And also we have to look beyond the heart. It's tempting to just focus on the heart being a post-cardiotomy or cardiogenic shock situation. But often, particularly in the post-cardiotomy setting, a number of other conditions can also coexist. For example, in a low SVR state, and also the associated lung injury, as shown in the previous case. And mechanical support, when we deploy mechanical support, we have to take all of these into consideration. So, for example, we have options of left ventricular assist device, right ventricular assist device, and VA Ecmo shown here. And this is the setup of the assist device and Ecmo circuit in relation to the native circulation. In general, VA Ecmo is the modality of choice. It bypasses the pulmonary circulation, and it can also help in the low SVR state associated with vasoplegia. There's a question of percutaneous or peripheral versus a central Ecmo approach. And again, this is taken from the recently published meta-analysis. And it shows that a peripheral or a percutaneous approach has no difference in mortality, but it does reduce transfusion requirements compared to central cannulation. So there is reasonable data to support peripheral cannulation even in post-cardiotomy shock. And there are other percutaneous modalities to optimize MCS support in cardiogenic shock. The first is to address the problem of LV distension associated with peripheral VA Ecmo. This is a pressure volume loop, for example, again indicating on the right panel, which is the left ventricle, indicating a rightward shift in the pressure volume loop, consistent with an increase in LV-EDP and LV distension. And we know that the impeller can be used successfully to vent the left ventricle. Here you will see the change in the pressure volume loop to a more triangular shaped loop shown in the middle here with the impeller support, reducing the LV-EDP and driving the pressure volume loop lower down the diastolic pressure volume relationship. So there are effective percutaneous options to vent the left ventricle in combination with VA ECMO. And early LV unloading is important in cardiogenic shock, and there's no real reason to think that this would not apply in the post-cardiotomy shock setting as well. And here is an example of a femoral approach, inserting a impeller CP to vent the left ventricle in combination with a VA ECMO. And then there's also another issue of transpulmonary blood flow. This is the schematic of the pulmonary circulation in combination with ECMO and systemic blood flow. If the lungs fail, as in the case of significant lung injury shown in the previous X-ray, then the transpulmonary blood flow will be full of deoxygenated blood, resulting in effectively a shunt and causing systemic desaturation. And here we also have a percutaneous strategy to try and overcome that problem by adding a return cannula to the pulmonary artery, effectively to a VVA, or some will call a VAV configuration, to deliver oxygenated blood into the lungs and reducing that shunting through the transpulmonary blood flow. And this can be done in combination with a VA ECMO circuit, reconfiguring the ECMO circuit. And if we need to vent the LV at the same time, there's no reason why we cannot insert an impeller at the same time. But in this case, this patient has a left ventricular assist device, which will vent the LV. And finally, there is also a percutaneous way of removing our decannulation. This is using the Manta Closure device, and we have done this successfully and use this to close the ECMO cannulation sites percutaneously and avoiding the need for surgical cut down for decannulation. So to summarize, the approach to MCS in post-cardiotomy shock should be largely planned as much as possible. We should take an objective and multidisciplinary approach and support early before multi-organ failure develops, perhaps with the use of cardiac power output index. There are a number of percutaneous options to support post-cardiotomy shock in combination with VA ECMO, from peripheral percutaneous cannulation, venting, and also decannulation. Thank you.
So, gentlemen, we had a chance to listen to your three talks, which were very comprehensive on an incredibly difficult topic. Let me first of all thank Abiomed to set this up for us, and to SCTS for allow us to discuss this very difficult topic under the roof of their annual meeting. So let's go straight into the issue of acute cardiac failure / cardiogenic shock. So for the listeners, if I want to summarize everything you said, basically we're pretty much back to square one, talking about the results. The results, Sam has shown us, the results have not improved at all over all those years. Whatever machinery we have used, whatever kind of system internally or externally, what network, whatever we have used, we have managed to get a few anecdotal cases through in better shape. But overall, at the broader spectrum, looking at the broader spectrum, we haven't really managed to improve. So what is if you had a choice now, what will be your 3 points to make this, let's say, to increase the survival from 60% to 80%? Shall we start with Payan?
Thank you for the opportunity to speak here. Well, my perspective obviously is a slightly different one than the one from my colleagues from UK. As you know, we are very liberal in using the mechanical circulatory support systems available today. My talk has been a little bit focusing more on the ECPR, or Rapid Response Ecmo program that we have here on site, which obviously extends then into some operative therapy modalities as well. Taking together the three major points is that being rapidly responding is very important to hit early, if you want to express it that way, and to escalate the therapy as early as possible, because we know that cardiac failure, which is present initially, can extend to lung failure in addition to that, and multi-organ failure, which is obviously very difficult to tackle. And then as a third point, it's important to de-escalate as early as possible in order to avoid complications such as bleeding complications and infections associated with multiple systems running on one single patient. So this is pretty much our experience of the past years with our program of remote ECMO program.
Can I just ask you a question specifically? So Germany is trying to be fairly ambitious and advanced in terms of rescuing patients even outside of the hospital, which with your sort of retrieval service which you have, it seems like you have gone very far, and there's obviously other centers in Germany who do the same thing on a regular basis. How does this how does your reimbursement system reply to this? How is this discussed? Is there any discussion about cost effectiveness or discussion about resources you need for those kind of activities? Anything?
And for the ECMO program, it's not. We have had some initial discussions about the Impeller 5.5, which we regard as particularly suitable for long-term support of the patients, because this one is particularly expensive as compared to the other systems. But now, since this year, they have having a situation where there is a certain amount of reimbursement already guaranteed, but this one has to be negotiated between each hospital,
right,
and the reimbursement agencies. So it's not a general reimbursement that is always guaranteed. But apart from that, particularly the ECMO program is reimbursed totally.
Right. So, Sam, what's your view on how can we, just the same question again, what do you think, if you had a wish list, what would you do to improve, to come from 60% to 80%?
So as I said, I think it's about how we deploy some of these technologies and to optimize the outcomes. So I don't think it's purely about improving ECMO technology, improving oxygenators, improving whatever cannula that we have. It's about how we use whatever we have now, because we know that those technology work.
Okay, Uli, your point?
So I believe I completely agree. And particularly, I believe it's a question about selection, proper patient selection, and then what we try to do a preemptive discussion prior to the surgery, when we identify patients where we know third time redo aortic root endocarditis, where we know that the right ventricle might struggle, that we plan it up from the beginning, that we don't that we just say, okay, let's come off bypass with an ECMO rather than waiting till the patient is crashing on ITU. I believe if you do it earlier on in a controlled measure, then I'm pretty sure that we can at least 10 to 15% increase the survival rate afterwards. If we can reach 80%, well, that's something it's quite challenging.
And coming back to this issue, Uli, can you imagine that we can implement in the UK a similar system like we just heard from Düsseldorf, where we go out and retrieve patients? Is this realistic for us to do?
Well, we do it already. So we have the retrieval program at the Brompton, and they run about 40 VA ECMOs and 70 VV ECMos a year as an insurance retrieval program. VA is a commission, but VA is not committed. We're not going to be paid. So we provide this service in order to retrieve patients from the south of England to bring it to Hereford Brom in order to offer them treatment options. But we're still struggling with reimbursement as to commissioning. But I believe this needs to be a role model, that it's not only for the south of the UK, it needs to be basically, well, the entire landscape in the UK needs to provide such a service.
Mm. So the second thing which I wanted to address with you is the bridge to something. So you all mentioned in your talks that there are various ways to get out of the acute setting of ECMO rescue and get patients to the next level. Is there a sort of a very simple way of addressing this? Because to me, it seems like it's very much dependent on availability, number one, what you have in the backup system, and number two, how you rationalize transitioning from one level of care to the next one. I thought Payan, he has demonstrated very nice single cases where he could show how even in extremely complex scenarios, he could get away with this and the patient would still survive at the end. Yes, these are only anecdotal cases, but I like to believe if it's happening in one patient, you might get away in a sort of more controlled fashion in future in a more broader sense. So what do you think? How do we approach this bridge to something in the future? Because at the moment, it seems like a very patchy understanding of the different steps, especially when it comes to the decision-making for transplantation. Shall we start again, Payan, with your view?
Yes, thanks again. I think, of course, you're absolutely right. These are anecdotal cases. I chose them because they somehow express the difficulties as well that we face every time when we have such a patient in front of us. I think the biggest problem is always, or the biggest challenge is to identify what is the problem of the patient. So what has been really the cause of his deterioration? And this is probably more clear in the OR when you have a perioperative failure, cardiac failure, than when you have a patient who has already been resuscitated for half an hour and you don't know out of the hospital what is actually the problem. So in this case, we obviously start right away with the most robust system. And then it's very important, as Dr. Lim has already pointed out, to have a multidisciplinary team that can offer the best chain of therapy and diagnostics, and to identify the true underlying problem as soon as possible. And that may lead us on the shortest way to a, let's say, stable condition that can lead to transplantation, for instance, or to a durable MCS. So in my opinion, the biggest challenge is the quick and clear identification of the underlying cause of deterioration in these patients.
Sam?
Yeah, so I approach this in kind of four phases, really. Sorry, excuse me. I think we have to divide the journey into four kind of relatively distinct phases. The first, I think, is the rescue, where we are trying to salvage the patient in critical cardiogenic shock, whether it is post-cardiotomy or whether it is cardiac arrest. I think once we achieve that, then we have to try and optimize the support, whether we unload the LV with the impeller, whether we optimize the vasopressors. So we have to go through this optimization phase to get the patient organ systems working. And I think we can really only consider transplantation or perhaps weaning of the support when the patient is stable. So we reach a stabilization phase. And then it's only when we achieve the stabilization phase that we should be considering either transplantation or weaning of support or durable LVAD. And I think those are the four kind of phases that all the patients go through. If we can't get the patient from a salvage or rescue phase to a optimization or stabilization phase, then there isn't an option for transplant or for durable LVAD or even weaning. So I think we have to kind of get the patients through all those stages using a combination of pharmacological management, vasopressors, inotropes, and different MCS modalities. And the MCS modalities that we use really is dependent on what the patient is like at the time. We need to kind of work out the physiology and optimize the physiology. So I think it's what we have the tendency to fit the patient into the MCS modalities, but I think it should be the other way around. We should be using all the modalities to fit to the patient's physiology at that time in order to optimize the patient clinical status.
I think that's a very good point. Yes, I mean, we are able now to offer more, isn't it? We have a much bigger armamentarium these days, especially with the new Impella systems, which can help us more through a couple of weeks, maybe a month or so even. Because with the Ecmo system alone, we all know if the patient lies flat on his back for 2 weeks, they have no chance to come out of this, or very little at least. So I think you're right. With all the armamentarium, then we have a better chance. But you know, this whole transplant idea, I don't think that's a realistic option, isn't it? Because transplantation is not happening, neither in Germany nor in the UK. So I don't think that seems like a realistic option. And also to assess the patient, to evaluate the patient, whether he's suitable, who is fast asleep on a full-size Ecmo. I'm not sure, given the present situation with donor hearts, anyone, neither in Germany or here, would support that. No, Uli, what do you think?
I don't think so. But of course, if you think about what are the limitations, ECMO is about a week, then we run in trouble with bleeding. Of course, we can always upgrade to the Impella 5.0, but Impella 5.0 is going to give us a little bit longer time. We run it close to 4 weeks, 6 weeks, but still we trouble with some kind of thrombosis and hemolysis. But of course, now with the 5.5, I personally believe we have another step forward for long-term support, either for recovery of the heart, or if we have a patient which we want to bridge towards transplantation. Even so, we all know that the numbers of patients who really qualify and reach transplantation are not very high. But I personally believe this is going to give us a new accent in long-term mechanical assist with mobility and mobilization with the transclavian access, for instance, that we indeed don't need to look at the patient laying flat in a bed, that he can be mobilized.
So we've got literally 10 seconds. I'll take the liberty to take another minute, as we have been promised. So quick question at the end is, we need trials, no? There is no trial available. It's all anecdotal stories, right? So in order to get out of this, what are we going to do next? First of all, do we build specialized teams? Secondly, how do we organize trials? Payan, you want to start? Briefly, 10 seconds.
One trial is already running, or in the almost running in Germany, and that focuses on the Impella support for ischemic cardiomyopathy and planned preoperative implantation for myocardial vascularization without a heart-lung machine. That's actually an excellent trial. I'm really looking forward for that.
Okay, Sam?
I think the trial should be about MCS strategy, not an MCS device. I think it's very much about how we deploy it, whether it's a conservative approach or whether we take a very, very liberal MCS approach. That would be my approach to a trial.
Uli, last word.
And it needs to be a national approach, because we can't compare Germany and UK as we learned today again. So it needs to be a national UK approach, I believe.
Gentlemen, it was a pleasure to work with you. I think we tried at our best to get some clarity in this extremely difficult topic, and I would like to thank you very much. It was a pleasure. Thank you. Bye-bye.
Thank you.
Thank you. Bye-bye.